India, no? So Indian Standard Time. So no worries. You are in Delhi,
I work from Chennai, sir. So
Chennai.
IVI head office is in Chennai.
Okay. Where in Chennai?
Chennai, if you would know Nungambakkam, very close to Shankanetralaya.
Okay. Last week I was in Shankar Nethralaya. So
For the walk.
no, not for the Ewok. I was there
Okay.
to present high order aberration,
Okay.
you know, at SN with
Yes.
Madhumati and her fellows.
Okay. Okay.
I'm not a SN alumni, so Ewok is only for SN alumni, basically.
I'm sure it's not so bad. So I think we'll go ahead and
Okay,
start.
okay. Let me. Where is my screen share?
Recording in progress.
So, good afternoon, all. Thank you for joining. My name is Agatha Susan Jeru, Program Manager, Professional Development and Research at India Vision Institute, Chennai. I'd like to welcome you to IVI's Excellence in Vision Science monthly lecture series on the session Contours of Clarity Decoding Corneal Topography for Smart Contact Lens Decisions. I'd like to take this opportunity to introduce our speaker for this module, Dr. Chandrasekhar Chauhan. Currently, Dr. Chauhan operates the Shekhar Eye Research in Thane and also practices in Los Angeles, USA. In 2004, he introduced scleral lens technology to India after acquiring it from Boston Foundation for Sight. Additionally, his proficiency extends to painting on soft contact lenses, excuse me, and RGB scleral contact lenses. Recently, Dr. Chauhan invented photochromatic scleral lenses for patients suffering from glare and light sensitivity. Thank you, sir, for taking the time to do this session. Welcome and over to you.
Okay. Thank you, Agatha, for that kind words and introduction. Uh, it's really an honor to speak with all of you here today, and hope I'll do justice to the topic given to me today. Let's see. Okay, here. Okay. So again, at the outset, I would like to thank the organizers of the Vision India Institute for this opportunity. Just a few minutes, I have written a book on keratoconus that was published last month at Bombay Ophthalmology Association. If you get a chance, you may just want to go on Amazon and check it out. It's freely available on Kindle, and if you want to purchase, it can be purchased paperback or hardcover copy from Amazon. So in this particular topic, I have no financial interest. As you know, if you are fitting a cornea, the importance of topography is immense because you are trying to use that surface as well as you are trying to modify that surface. So you should know what you are doing to get a perfect results. So basically topography is most of the topographies are Placido disc type of instruments where there are some concentric rings that is projected on the cornea, and whatever is the reflection coming out of the cornea is measured, and how much is the deviation in that is calculated into software, and that is how you get the ups and downs and curvatures and powers and all that sort of thing that is calculated in the meaningful manner, color coding, numbers, etc., etc. There is another technology called tomography, where Scheimpflug image is captured, and the advantage of that is it not only gives the front surface, but it gives the data of the back surface of the cornea as well, like this. Okay, so of course we can't do anything about back surface, but there are a lot of other issues when you cannot improve vision beyond certain extent, even after putting a scleral lens or correcting front surface irregularities or aberrations. The back surface of the cornea plays an important role in those, and then you know what is going on. So as an optometrist, we usually use the front surface information for fitting contact lenses. That is today's topic. But for a deeper, understanding and intervention with surgical or any other ways, we must know the back surface also. There is another machine that has recently launched in the US called Gaudi. It's an amazing machine, and it gives the almost 20 mm of eye information, and there are a lot of features in that. You don't have to put any fluorescein in that, and you get a wonderful data of the front surface of the cornea, and you can, using that data, you can design your lenses, corneal GPs, orthokeratology, scleral lenses. I use for my scleral lenses, and it's really amazing. Lot of control they have given. Before that, the eaglet eye profiler came into market about, I think, 4 or 5 years back. It's made in Netherlands, and it's doing wonderful. In that, you have to put a fluorescein and take 2 3 images, and the software will merge those, and it will give you this kind of a data. And best part of that is that software, that machine is connected with all these manufacturing companies in the US: One Feet, Zen, Scleral Lens, Boston Scleral, Aquilens, Excel. So the data goes directly to the company, and they can make a lens and send it to you. It's, they have made your life simple and easier. Even without fitting your trial lenses, you can get a lens. Of course, to fine tune, you have to do a final refraction on that lens, and the second lens which comes with that power is your final power. Medmont has been there since long, and it is a gold standard for fitting corneal RGPs, especially reverse geometry lenses. And today I'm going to talk much about Medmont, because that is the workhorse, and that is the useful lens, the useful instrument tool at our disposal. It is much cheaper than the rest of them, other two I mentioned, and it is really workhorse. Now, what is the difference between keratometry and topography? Most of us has a keratometry. When you do autoref, it is already inbuilt K1, K2. Now, K1, K2, as you know, it's only 2 data points. But cornea is 11 millimeter, 12 millimeter, and only that 3 millimeter information is not going to helpful to put a, say, 10 lens or 12 11 lens, or whatever, bigger lens. So you need a more data. So most of the lenses that we are going to use this instrument is for the orthokeratology. So I am going to talk a little bit about orthokeratology, because that is where you are going to use this data and instrument. We are reshaping the corneal epithelium. I'm just going to show you a few slides here, and it's a reverse geometry lens design basically. And okay, so this is how it looks. So it is, the central is like a base curve, you say, in our RGP terms, that will put a pressure. So it's a push and pull technique, where you push at the center, so epithelium starts getting compressed, and there is some reverse curve that has a little extra space, and that creates a pull. So the epithelium gets swollen there. So you get a lens of a epithelium, and that is what creates the refractive correction. What you're looking for is the bullseye pattern, that is the central area which is getting depressed and giving you that refractive error, and periphery where you have a reverse geometry curve, you get a plus power that is used for myopia control also. So as I said, keratometry will give only 3 millimeters, whereas to fit corneal RGP you need at least 10.5 millimeters of data, and if you want to put a scleral lens you need at least 15 plus data to design your lenses. Most of the ortho K lenses are fitted on a flat K. If there is a difference between the meridians, you have to design a lens which can accommodate everything. That means you have to go for a toric design. What you're looking for is eccentricity, shape factor, sphericity, because that will give you leverage or the area where you can reshape it. If your eccentricity is not good, then you cannot actually push enough to get the refractive error corrected. So if you have more than 0.5 eccentricity, you can get away with most of the refractive. If it is less, then you have to do a lot of adjustment and create a lot of extra curves to address that situation. The horizontal visible iris diameter decides the diameter of the lens. You want the largest diameter lens so that the lens can be centered properly. So usually it is the 95% of the HVID, that is horizontal visible iris diameter, or VVID also can be taken from the instrument, but 95% of that is the diameter of the lens. There are some lenses available in the market which are smaller, but then there is a lot of trial and error going on, and the lenses can behave erratically, like lenses may go up or down. Now these lenses needs to be worn under the closed eyelid situation. That means when you are sleeping, okay, then only that push and pull will work, and the epithelium will swell or get compressed. Now if the lens is not positioned properly on the cornea under the closed eyelid, you will get something because you are not seeing the patient during the sleep, but patient is coming to you and you are going to measure the uh, uh, curvatures of the eyes with the topography, and you may see something like this. This is called smiley face. Now if you are getting smiley face, that means the lens is riding high when the patient was sleeping. That's why you are getting this. You want it to be in the center, but this is now going up. Fluorescein, its initial evaluation can be done with fluorescein, but fluorescein will keep on changing every few minutes. So it is, not a dependable parameter, but yes, it will give you a instant information whether you are going correct or not. Here you are looking for a central touch and peripheral touch, and the fluorescein pull in the center. Now this is a typical toric lens fluorescein, what you can see. This will not work because this is full fluorescein there, and it is not causing any compression. To get the perfect information, what you are doing is by the subtractive map. So first information is virgin cornea. When patient walks in, you take the topography information, then you put your scleral the ortho K lens or reverse geometry lens, by which the cornea gets modified. Now how much is the modification? That you use a subtractive map. So you pull at the first map, and then the second map you ask them to subtract, and you will get this beautiful image here, where if it is in the center, that means your treatment is working fantastic. It's called bullseye pattern. And in this cross section you can see how much is the exact power you are achieving and in what area. If you are doing it for the adult, you want this reverse zone to be more than 6.7 mm. If it is a myopia control, you want this reverse zone in the 5.5 mm, then only you are going to get that plus power or hyperopic myopic defocus there. So this is what the beautiful myopia control lens will look like. This is called a red ring or plus ring, which has to be in 5.5 millimeter zone to get a myopia control effects. So topography will tell us whether your ortho-K treatment is successful or not by looking at the frowny face, or this is a frowny face when the lens is riding low. This is a smiley face where the lens is riding up. What you're looking for is the bullseye pattern. If it is a bullseye pattern, your ortho-K lens is working well. So the importance is to get the well-centered lens. And as I said, to get a well-centered lens, you have to use the diameter 95% of the HVID. That is just one method, but that is the important aspect, the diameter. So that will center. But lens may be loose or tight, and that can be modified looking at the topography. So if the lens is riding low, then you have to modify the fitting curvatures, sag height. Base curve remains the same usually because that is what is giving you the refractive error correction, but the second curve, third curve, fourth curves needs to be changed to bring that sag up or down and make the lens fit properly. The alignment curve is actually your flat K, and that also will be almost fixed most of the time. Now if you have a limbal to limbal astigmatism, which you can see on the topography, a regular spherical lens will not work in this case, and you have to go for a toric lens, toric reverse geometry or toric ortho-K lens. If it is something like this, in the central area only the astigmatism is there, then you can get away with a spherical lens. So apical astigmatism, that is called, can be managed with the spherical lens, and if it is a limbal to limbal astigmatism, you need a toric lens because both the meridians has to be managed properly. So there are two ways of capturing topography. Mostly we just ask patient to look in and then you take the readings. But if you are trying to fit a lens on the cornea, visual axis is not in the geometrical center of the cornea. So when you ask patient to look at the central red dot, the eye is slightly deviated and you may get a little false information because the eye is little off. But if you want to get a central curvature, ask patient to look few lines on that ring on the right or left, whatever eye you are trying to capture, and make sure that rings what you see is in the geometrical center of the cornea. If you do like this, then you are getting a good capture. Okay, you are going to get a perfect information and you will not go wrong anywhere. But if you just ask them to look in the center and take the reading, you are missing on the periphery and you may get a false readings. So that is one point which I can tell you. Ask patient to look little right or left till you get the exact center of the geometrical center of the cornea, and take multiple readings so that you can get a well calibrated or well centered image to choose for final designing. So this is an example of some good capture which is covering the whole cornea in the center. Ask patient to look straight, make sure that the lens, the cornea is well nourished, in the sense there is a nice tear film there, and then you can ask patient to hold the upper lid little stronger, or ask patient to look straight with wide open. If patient can't keep the eyes wide open, you can use a Q-tip cotton bud and you can hold the upper lid, so you get a full cornea. I know it sounds for me to tell it is easy, but you have to do this. If you do that baseline capture perfectly, the future problems will be solved and you will be more successful. So spend that initial time to get the nice image. Um, so you can get like this 4 5 6 images, and then you can compose them together so that you get a much better data points. So ideally you should get about 12 millimeter of data points for a good lens design. First, virgin cornea is most important before attempting to put any lens on the eye, because the moment you put any lens, the cornea is going to get disturbed and you are not going to get a perfect. See, it's only 50 microns of thickness you are talking about, is the thickness of the hair. And if you put any lens which is not proper, it is going to cause some kind of epithelial damage. The first two layers of the epithelium will immediately go away, because of the friction, and you are going to get a false information, and that to correct afterwards is going to be difficult. So you can set up the scale also looking at the accuracy that you want. There is a feature in that software to calibrate, or you can adjust this the scale to get the more and more details of the corneal curvatures. What maps you are looking at is axial, tangential, elevation, refractive, wavefront, and height. Most of the time what you are looking at is a tangential and axial maps. Okay, for contact lens fitting I'm talking about. Corneal powers will tell you how much correction you achieved and what was the refractive error. That will help you how much correction you could achieve with the uh, whatever lens you have put. Tangential map gives the shape of the cornea. That means what shape you changed by reverse geometry lens or ortho-K lens is going to give you the exact detail by tangential map. And if you use a subtractive map, you will get a more pronounced effect. Elevation map is the basically height of the cornea in different meridians. See, it may be useful for keratoconus information, that's it. But if you're fitting a scleral lens on the keratoconic eye, this topography has no meaning except how much vault you need. But if you're using the eye profilers, then of course it is of importance to get the elevation and the height, to so that you can keep about 200 300 micron of clearance in that area, and you can make the scleral lens not touch on the cornea or limbus. But if you're talking about ortho-K, then you're touching the lens on the cornea. In fact, you're pushing the lens in the cornea, and you should have the exact details. So coming to apical astigmatism, you can get away with the spherical design lenses. So about 23 microns of difference between two meridians, you can get away with that. But if it is more, say 330 macrons or more, then it is a limbal to limbal astigmatism, and you cannot correct it with the spherical lens. So you need a toric lens. About 5 years back, there was no toric lens. We used to manage with spherical lenses, and in cases where there is a high astigmatism, that means more than 2.5 cylinder, that is corneal toricity, we used to say, sorry, you are not a good candidate. Now we have a design where the two meridians can be designed separately to address that, and you can have a toric lens. Even you can correct up to 3.5 4 diopters of corneal astigmatism with the toric lenses. Again, good centration is important to get a final good fitting. Limbal to limbal astigmatism, definitely switch over directly to the toric lenses. Don't spend your time and money on a regular lens. You can always compare your before and after data with the software in the topographer machine, And as I said, the initial evaluation can be done with the fluorescein. See, this is most important. See this black touch, and in the center. So center is going to decide the refractive error correction, and this will decide whether you are going to achieve that suction effect to get that treatment done on the epithelium. If there is a fluorescein in this area, that means there is a leak, and it will not cause any uh, proper suction. See, like this is a leak. This is not going to give you the final fitting. Patient may see a little bit better, but it's not a fully corrected lens. So this is how the spherical lens on a toric cornea will look like, and a toric lens on a toric cornea looks like. This is what you want to see, not like this. See, this is a leak here, and if you see a leak, then you are not going to get a holding time good enough. You may correct it a little bit, but there won't be holding time. If you get this type of pattern, then you are going to get holding time of 12 to 14, 16 hours. Holding time means patient can see clearly from morning till evening. So subtractive map, as I said, is most important, where you can see what changes has happened, and then you can modify the treatment zone position, treatment zone size, or the diameter of the lenses. So these are the four maps that we are looking at: bullseye, smiley, frowny, and island. Island is when there is a less sag, it is not pressing properly, not pressing, compressing in the center properly. You will get a little bit of island here, and that will not give a full correction, and it may give a little distortion. Now, using this information, what I did is I purposely create island in the central 2 millimeter zone to correct the presbyopia in the adult myopic patients. When they have been using my ortho-K lenses for long, and now they don't want to switch over to spectacle for reading, so I give this presbyopic ortho-K lens, where I purposely induce this island. But in normal patients where there is no presbyopia, you don't want this island. Okay, so this is how the subtractive map, the lens looks like here, just a photographic image. Again, you are checking the tangential map and measuring this in what area, what zone it is. If it is an adult, you want this to be more than 6.7 mm. If it is for myopia control, you want in less than 5 mm. Central zone, as I said, if it is a sag is excessive, that means the center is not pushing well, you are going to get the central island. See, this is just a first image, but if you use a subtractive image, you are going to get that effect enhanced, and then you know exactly what is going on there. So subtractive image is most important for all the patients. Same thing, smiley face, and this is a subtractive image. So you here you can change the alignment zone to correct that. In frowny face, again, alignment zone, you can tighten it a little bit, you can change the sagittal height, the diameter also sometimes it needs to be changed. So this can cause a lot of aberrations in the center. Okay, so you have to make sure that it is in the proper center, that is a bullseye pattern. You want something like this. So in summary, basically you have to start with a good capture, make sure the lens is properly centered, not displaced. Apical and limbal astigmatism has to be taken into consideration before going for a choice of a lenses. Lenses can be designed with some softwares like RGP Designer, or nowadays simply you just send this K1, K2, topography, refractive error, and HVID, and the lab will design a lens for you. But you should know, as you go advance in the fitting specialty lenses, it is better to have the knowledge, and slowly you will need to intervene and start making changes by your own. So basic terminology is base curve, reverse zone, you can say alignment zone, which is holding the lens in the center, and the peripheral zone, that is allowing the tear exchange to happen, and the diameter of the lens. Eccentricity, as you know, sometimes it is very confusing. So if you have, one eccentricity, you are not going to get any effect. But if you have about zero point 0.5, then you are good, you are at a good position, or even zero point 0.3 is good, because you can modify it, you can press it. So this is the designer software that I use, rgpdesigner.com. You can get for a monthly fee of, I think, $29, and you can do, whatever designs you want to make in that, and that file you can give it to your preferred lab, and they will make the lens for you. This is little for a more advanced. I advise you to go check for Randy Kozima's YouTube channels, and he has given much detail about the topography and how to use that and how to change the parameters and a lot of stuff. So I will recommend you to check out his YouTube channel. I also learned a lot from him. These are my references. If you have any questions, I'll be happy to answer. Before I go into that, again, my another book was published yesterday on Ganesh Chaturthi, called Fifth Dimension. This is where the ancient wisdom meets the frontiers of science. So this is a little bit of more of a spiritual and a scientific discussion I made. It's called Fifth Dimension. If you get a chance, it is available on Amazon. Thank you so much. I'm open for questions.
Thank you, sir. It was a very nice session. Audience, maybe I will give you the time to ask your questions. Either you can put it in the chat box, or you could also use the raise hand button, and we'll give you the controls to speak. Sir, before the questions come in, congratulations on your publication.
Thank you.
If you could please send us the links.
Yeah,
Yes,
sure,
it'll
sure.
be very helpful. We could share it with our participants as well.
Sure,
And next time when you're in Chennai, I would love to meet you, sir. Please let me know.
definitely. September first week, I'm coming there to talk about these iodine aberration lenses. In fact, we are seeing some patients also.
Oh, that's wonderful. So where are
Yeah.
you
SN,
giving the talk?
SN, SN, SN.
SN.
No
Yes.
other hospital invites me.
Please, no. So, okay. So, since no one has yet posted, I'll start some questions that we had received earlier through email.
Yeah, yeah.
One question was from a person who has a clinic, and that person wants to know how do you communicate with patients so that they understand the scan much easier? Like, what are the points that you touch on?
See, to show to the patient, see, I'm not here to educate patients on how I fit lenses. So there is no need to go in depth. But yes, looking at the colorful maps, patient get, wow, this is
Yes.
something happening. So use that and tell him, hey, here, there, this is the elevation, this is what has happened. You can show the subtractive map, and you can show. See, this is only for intelligent patients. If you try to talk with, you know, uh, see, that is a whole different topic actually. It's a psychological, evaluation of the patients. If you have an engineer patient, he wants to go deep, and then you are in trap, because the moment you show him the map and start explaining, hey, this is your center, this is your pupil, and this is your reverse zone, then he will go on deep, and then slowly he will ask you from which lab you got the lenses, can I have the lab information, can I write to the lab, say they want to go bypass you. That is our, people's mentality. So I show them the map, definitely. Yes, this is what it is. And if they are interested, I will definitely share a PDF with them. But I don't spend time in explaining the map much, frankly. Okay. Only what I will show them is, this is your before, this is the after, and your treatment is going well. Because see, neurological adaptation is also important, and you have to make sure the patient understands, and he has faith in you, and he knows that yes, whatever you're doing is the correct, and you exactly know what you're doing. So till then, yes, you must show the maps, but I don't go much into detail, and See, even today I have spent like half an hour with you. You must have understood only 4 or 3 slides out of this, right? If you are actually practicing, if you already have a topographer with you, yes, you will know more. But if it is only beginning, then it's very difficult. So for specialists, it is difficult. How difficult it is for the patient. So yes, you can definitely share with that.
Thank you, sir. I understand the question. So we have a question from our team who's doing vision screening. I think some of them are very interested in this particular topic. So how do changes in corneal topography after prolonged contact lens wear, let it be soft, RGP, or scleral, correlate with the refractive shifts and the
Oh,
biometrics or the health of the
definitely. See,
ocular
what happens
surface?
is the cornea, as you know, is the first and most important refractive surface of the most of the curvature. The refraction is happened at the cornea. The moment you try to interfere with the lenses, your RGP lens or soft lens or whatever, the 50 micron of epithelium is going to get affected, even if it is a soft lens. Using that technique, I think there is a company called GOV. They came up with a soft ortho lenses, right? Because you just need to modify only that 50 micron. If you are fitting a regular corneal GP lens, and if it is very old, it can, when you remove the lens like this, the lens can get warp, and that warp lens, if you use for a longer time, your epithelium is going to get that shape, and that is going to cause aberrations. Now, as long as they are in a like a regular astigmatic manner, then patient will not much complain. But the moment they are irregular, then patient is definitely going to complain of halos, glares, multiple images, similar like a keratoconus. So the moment you take a map, you know what is happening. You can tell patient directly, especially when patient comes for keratoconus evaluation. First thing what we do is take a map, and from the map only we'll tell them if it is there is a lot of aberrations or different powers in the central 3 millimeter zone. You yourself can tell patients, hey, this is what is happening to you, and patient will be surprised. Oh, how do you know? Looking at the map, you can tell them there are a lot of powers in that center area, and that is causing these multiple images or ghosting or glare. So map can tell you the story of the cornea, and that is why they made it into colors, like, so red, blue, green. So green is like a okay, yellow is like a okay, green and red, blue and red is too much deviation from the center. So basically what is happening is they consider one sphere, and if the cornea is down, it's steeper than the spherical value, they will give red, and if it is elevated from the regular sphere, they will give blue color, and in between green and yellow. So it looks nice for the eyes, and you understand the changes in the cornea immediately.
There is one. I'm not sure who's the person who's asked it, but sir, could you please explain a bit more about reverse curve? So this is one of the participants who have sent this question.
Correct, correct. Very nice, very intelligent question. See, reverse curve is important for getting the holding time, the effect of the orthokelens. When there was no topographer, we used to do orthokeratology, so called, by creating a flat RGP lenses, and some patient used to see clearly, some patient not. That time the RGP material was not more than 50 dk, so it was not successful, but that is how we started. So everybody had that interest. If you go in the history of orthokeratology, Chinese people started putting some bags on the eye and that kind of stuff. So coming to his question, so central about, say, if I'm doing say minus 3 diopter correction, my base curve is about, say, 44 diopters. So my base curve will be 4.41 diopters. Okay, that is like a stamping. Now that, suppose if it is a adult or whatever, suppose a adult, so my Base curve optic zone is up to say 6.6 millimeters. From 6.6 millimeters to say 7.8 millimeters, I need a reverse curve. Now the idea is whatever you pressed here has to get accommodated in that reverse zone. If you see my ring on the finger, if I am pressing it here, the tissue gets compressed here, but there is a little bit of swelling here. So that tissue gets little elevated or raised or swollen there. That swelling needs to get accommodated in that reverse zone. Plus you have to think of something called Jessen factor. Jessen factor is like a, when you remove the lens, that pressure is gone and the lens will bounce back. So every company has a different Jessen factor. Some people will have plus. So all the lenses of ortho K lens, if you measure on a slit on the lensometer, they will show a power of plus 0.75 or plus 1 or plus 1.25. That depends on the company. Why that is there? Because the moment you remove that lens, the patient is actually overcorrected by 0.75 in the morning. By afternoon it is 0. By evening it is undercorrected by 0.75. But the patient doesn't realize that small change. Okay, so that is a Jessen factor. And the reverse curve. The every company has their own way of calculating how much reverse curve they want to keep, and there is a formula to calculate, but it's just a standard formula you have to modify. So when you go in that software mode, you have all those curvatures at your disposal, and you can tweak, you can change the curvatures, you can change the parameters of reverse zone, and in the software they will show you what changes you did is how it is affecting on the, there is a simulation of fluorescein that will tell you what correction happened or what deviation happened because of that curvature, and you can modify. So it is important, the reverse curve is most important, because flat, see, the alignment curve is your flat K, the base curve is your steep K mostly, and the central, that reverse zone is the actually trade secret.
Thank you, sir. Any other? Okay, we do have one more question. How do posterior corneal changes not visible on anterior maps influence specialty lens choice?
uh, can you specify which lens you are talking about? See, if it is a keratoconus, then the back surface of the cornea will matter, right? For a regular myopic cornea, I don't think much changes are seen in the back surface of the cornea, but in keratoconus, yes, there is. If you do a pentacam and if you know there is a something wrong happening, see, the nature has its own way of correcting. If you have seen many times, you see a corneal curvature of say astigmatism of 1.5 cylinder, but when you do a refraction, you get only 0.75, or sometimes you get 3.5. So there is a, the whole eyeball is contributing to that refractive error, right? You are not only controlling the front surface of the cornea. So that is where the back surface, the lens tilting, the back surface of the retina, so many factors come in, and that is where the high order aberration measurements are now important. So I have a machine called Ovid's aberrometer, or Pentacam has a AXL wave machine, or even iTrace machine is there, which will measure the aberrations. So those are the aberration of the whole eye. The front surface of the cornea, that aberrations can be corrected with your contact lenses, because it has a fixed curve and the water will go in that irregular zone and it will correct. But the back of the cornea you cannot correct. The lens and the inside of the cornea, that you cannot correct. But that now can be corrected if you can measure those aberrations with some machine, and then we apply that on a front surface of the scleral lens. Just like, if the eyeball is plus, you put minus lens. If eyeball is minus, you put a plus lens. Same thing here. Now the aberrations you consider as a wave form, and you put a negative aberrations on the front surface of the lens, and it can be corrected. Now, to correct the aberration, the scleral lens has to be non-rotational. It should not move. It has to be perfectly balanced and center. Because if you apply the aberrations and if the lens moves, you are causing more problems. So first of all, you have to get a perfect fitting, and then you measure those aberration and apply on the lens, and you can get rid of those. uh, it is really wonderful for keratoconus patients who are complaining of difficulty nighttime driving, halos, multiple images, ghosting. Even with a regular lens, it is like regular spherical or Boston sight lens. If you can't correct them, then you need to apply, measure these aberrations, and then apply it on the front surface.
So the participant was specifically asking on specialty lens practice, specifically ortho K lenses. So he was meaning
Okay.
to ask, does it have any influence on these specialty lens?
In one one sentence, no. Okay. See, the moment you put the lens, you know it's a myopic, regular myopic eye, and if you are correcting with the ortho-K lens, that is a reverse geometry lens, right? So you you have only control of the front surface. The back surface you can't do anything. If you can get a good vision, 6:6 vision, well, fine. If you cannot achieve that, then you, of course, if you have a pentacam or something which can tell you the back surface, though you know the reason, and you can explain to the patient, hey, this is what is happening. But that is not the end of the story. You can still correct the maximum amount by reverse geometry. Patient is always happy. We have patients 6'9", 6'12", they're happy. They were not happy, but they know that they can manage. If it is a if you are decided that you are going to go ahead with the ortho-K lenses, it is not a keratoconic cornea, go ahead, no problem. Even if patient is 6'9", no worries. Even when you do the ortho-K lenses, and when you do a refraction on like follow-ups visits, like 1 month, 6 months,